to call roll, please.
Director Garza is absent. Director Kim?
I'm on the phone. I'm present.
Oh, I apologize. Director Sorrell? Present. Director Webster Cross?
Present.
Chair Bod?
Present.
And Ms. Merriweather? Present. You have a quorum.
Thank you. I'd like to entertain a motion to allow Director Garza and Webster Cross to remotely participate in the meeting. Voting.
So moved.
Second. There is a second. Motion has been made and seconded. Is there any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed? Motion, ayes have it, motion carries. The next regular meeting of the Quality and Patient Safety Committee is scheduled for Friday, June 6th at 9 a.m. Is Victor anywhere else to provide in person or virtual?
No
Oral
testimony today.
testimony?
Nope.
Thank you. All right, we have action items to approve appointments and reappointments of Stroger Hospital Department Division chairs, none being presented at this meeting. So now we'll go to the EMS MEC reports and action items. The Stroger Hospital and Providence Hospital med staff action items are being presented for approval. I'd like to invite Dr. Neha Shank, Vice President of Stroger Hospital, Executive Medical Staff. Oh, sorry.
Dr. Shane?
Dr.
If you
Shane,
could
want to use the mic?
Step over to the mic.
So, yeah,
There you go.
thank you.
Sorry. I believe you have received electronically the report of the Credentials Committee, and those were approved at the EMS meeting on Tuesday, May 13th. And I also have the summary from the Hospital Quality Improvement and Patient Safety Committee. If it's okay, I'll present that as well. I'll give you some highlights from the March meeting. From our stroke committee, a total of 378 stroke patients were managed by Cook County Health and Hospital in 2024. 7 of these patients received TPA and subsequently underwent thrombectomies, indicating timely and advanced intervention for eligible cases. As for stroke education, we are meeting our goals for over 90% of stroke patients to receive comprehensive discharge instructions. And the stroke committee has paired with nursing and are meeting frequently in order to continue to improve this. We have a stroke coordinator who provides supplementary instruction as needed. And then from the patient relations standpoint, we are currently maintaining 100% compliance with the CMS requirement for issuing an acknowledgement letter to patients within 7 days of grievances. And we are over our internal goal of 90% for grievance closure rate. We're hitting 95.56% currently. We have no action items for the QPS committee other than approval of these.
Thank you. Any questions or comments? Director
I
Mary?
just wonder, what's the mortality rate, or does everyone go home after you provided the intervention?
For the stroke patients,
Yes.
let me just see if I have that in my paperwork.
Yeah, and if it's not available, we can have it and follow up.
Okay.
But,
I don't have that, but I'll make a note of it to get back to you.
yeah, thank you.
Thank you.
Thank you. Other questions, comments? Anyone remotely have any questions, comments? All right, thank you, Dr. Shane. We have Dr. Paul Aldretti expected, who's remote, President of Providence Hospital Medical Executive Committee, will present any reports and present medical staff action items for committee consideration. Dr. Aldretti, go on.
Yes, hi. Good morning, everybody. Sorry I couldn't be there in person. I had to work overnight at Providence last night. So I'm asking, I'm presenting our credentials minutes for reappointment and appointment of medical staff. The credentials meeting at Providence met on April 22nd. And the test was approved, and this was also approved at the May 9th Medical Executive Committee at Providence. And I'm asking for your review and approval, and I am here if you have any questions or comments.
Any questions from, directors? I'd like to entertain a motion to, approve item 3B, Providence Hospital Medical Staff Appointments, reappointments, and changes.
I'll make the motion.
Thank you. The motion's been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed? Ayes have it, the motion carries. All right, thank you, Dr. Albright.
Thank you.
We have the April 14, 2025 minutes. These are expected to be approved by the board at the May 30th board meetings, or currently in draft form are being presented for the committee's correct consideration. Any corrections that need to be made to the minutes from the directors? I'd like to entertain a motion to approve item 3C, the minutes of the QPS committee meeting of April 14th.
Second.
Motion's been made and seconded. Is there any further discussion on the motion? Hearing none, then all in favor say aye.
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 All opposed? Ayes have it, the motion carries. All right. We will have an update on Stroger Hospital Leapfrog safety grade that's reviewed by Jennifer Rusnich and Irene Martin. Good morning. Thank you.
Good morning. So we're happy to report that the leapfrog score, safety score for Stroger Hospital is a B, and we're trending very close to an A. And we want to commend all the efforts for all the staff and the leaders. And I'm going to turn it over to our Director of Planning and Analysis to talk about the trending and some of the opportunities we have to get to the A.
Good morning, everyone. Can you hear me okay? So right now, Stroger and Provident are both in the open survey window time. We will be submitting for Stroger and Provident by early summer this year. This survey is all publicly reportable, and a portion of the questions and the public data is used to make the algorithm for the safety grade, so it's kind of a mix of things. Stroger's trends are shown here on this graph from 2017 through spring of 2025 with our recent release of a B. We are recently up and down, but we're holding tight at a B, and we're only 0.142 points away from achieving an A. So we're really close. And on the next slide, you're going to see the information that is driving this safety grade, in particular, not the survey, but the portions that make up the grade. And so there's a column the third column from the right, which is leapfrog means of the results of other hospitals that have submitted for spring 2025. You can see really quickly the red areas are areas that we are below the mean, and then in green where we're outperforming the mean, which is great. And in fact, 54% of the time, 12 out of 22, we're doing better than leapfrog average mean areas, and 45% we have an opportunity. While I'm happy to report this, a lot of these opportunities are already nested in our OpEx work, which is coming up next. We've strategically placed those areas of focus with our leapfrog and CMS star rating improvement efforts to align and kind of work on stuff strategically so that it works together to improve both areas. And one other thing I mentioned about this, I'm not going to go through each row of data, but the data, particularly as public reported, is typically lagging. And so it can be a teeter-totter, a whack-a-mole effect if we're not sustaining our efforts. Something else goes down that we didn't anticipate. So, but in any case, I'm just happy to report where we're at. You know, overall, we're doing better than half. And yeah. Any questions?
In terms of, it looks like trending close to the A. Are there any particular actions that you think will be helpful to continue to trend in that positive direction?
Patient experience, absolutely, is a big proportion of this percentage in the structure process area that we need to bring up. And we are trending in the right direction for nursing domain, which you'll find in the next presentation. And so eventually that should replicate through the systems to leapfrog, and we should start to see that. It is a slow effort. It's a hard measure to bring up quite quickly, but it's moving in the right direction. And then as far as the outcome section, obviously sustaining where we're at below the mean. And then, I know there's been some great work in the PSI effort that we're going to start to see replicate through even lower than where we're at today. And then I do think that CDIF and CAUTI coming down a little bit would be beneficial. But we're still below national, according to CDC, I believe, so. Does that help?
Okay, yeah, thank you. Other questions here, directors?
I have a quick question about some of the outcomes. Maybe I'm not understanding how to read this result. There are several red color boxes here. It looks like we're doing better than the national average, like, for example, falls and trauma.
Correct.
But why is it still red?
So falls and trauma was on the right, the column that's red is the most recent release for public reported, so 0.425. The column on the right of that is 0.384, and we're above that. We'd want to be below that. So technically some of them are inverse or, yeah.
Thank you.
You're welcome.
And you mentioned that some of these that are in red, though, are still above the national average.
Better than, yeah.
Better than that.
Yeah.
Better than the national average. It'd be nice to have that to also juxtapose.
Okay.
To see what's currently happening here, what the mean is for the group, but also the national average. And that also sometimes gives a motivational input to make sure that these changes over each year, you can certainly tell that the trends are improving. But since those changes are just incremental,
Yeah.
maybe knowing, hey, we're above the national average, now we're pushing toward even more, even better with the mean. That can also be helpful for us to be able to
Absolutely, not a problem.
Okay, thank you.
Yeah.
Okay, and any questions from the remote participants? All right, thank you. Yeah,
You're welcome.
well, appreciate the work and the report on this, thank you. All right, we'll go to the operational excellence dashboard, goals and tactics, of Stroger Hospital site review from Irene.
Okay. Irene Marks, I will be reporting on behalf of Stroger's leadership, the operational excellence work. Stroger Hospital has 9 focus areas for their operational work. And what you see here represented by the chart is each one of those measures, and the outline, which aligns with the legend, tells about the 12-month rolling performance. Next slide. So those are the 3 remaining areas. So overall, we've had 1 measure that met the stretch goal. We have 4 that exceeded the target. We have 2 that are above baseline with improvement, and we have 2 that are not improving above the baseline, and I'll get into that in a moment. Next slide. So the measures are spread across 4 different domains. The first domain is patient experience. We have the physician communication, which we are meeting the target for the 12-month rolling, and the monthlies are also meeting the 12-month rolling for the target. On the nursing, which Ms. Rafinich mentioned earlier, the nursing is exceeding the 12-month rolling target, but under the monthly, they are actually meeting the stretch goal quite consistently, and we're hoping that will impact our leapfrog score down the road very soon. The next domain is our clinical outcomes, and the first measure is related to our mortality index. Now, we've had some variation here, and currently we are not meeting the 12-month, the target for the 12-month rolling for the baseline. But we are looking at this. There's a new work group that's been established. They're looking at the tactics, and they are putting in some new measures, and they're doing some chart case reviews, and they are going back to the physician leaders to try to align the work with them. The next measure is our patient safety index, where we are, we're above the baseline for the improvement for the 12-month average, and for the monthly, we are also above the target and meeting those target measures. And so we're doing good work, and we're trending in the right direction in that area. The next measure is related to our sepsis bundle compliance. And for that, we have seen some downward trending in that area for the rolling 12 months. So we are not meeting the baseline, and the monthlies are not either, but we have gone back to our work groups, and we're looking at the sub-tactics to align with the current tactics that are in place. And what they're doing is also doing some changes to the sepsis bundle, the alerts, and also looking at the documentation more, just to try to see if we can kind of tease out what is actually falling out and making sure that we can meet the expectations here. Next slide. The next domain is our readmission. And here we're measuring our COPD readmission, and we're doing tremendously well in this area. We are exceeding the expectations for that measure for both the 12-month rolling as well as the monthly. The next measure under this domain is our post-hospital appointments. And so we are exceeding the target for this measure for the rolling 12 months, and for the monthlies, we are actually going above the stretch goal for that one. And last but not least, the throughput domain. The throughput domain, we're looking at the length of stay for our hospital, and it looks like we have made some improvement in this area. So we made improvement above the baseline for the 12-month rolling, and we're starting to see some improvement toward the target. We're meeting the target for the monthly. So we're happy in the direction that this is going. And the last measure under this domain is the length of stay for the ED. And so they have been doing a tremendous job with the length of stay for the ED discharges. We are exceeding the target here as well for the 12-month rolling. And for the monthlies, we are meeting the stretch goal. So that is the conclusion for the Stroger Operational Dashboard. Does anyone have any questions?
I just wonder if you're working with any other groups, any other safety net hospitals, around the country for the sepsis bundle, because that is probably connected to the mortality rate as well. So I just would encourage, most hospitals are struggling with the sepsis bundle and the detection of sepsis at onset. So there may be an opportunity with others. I would go through the leapfrog and look for the large safety net hospitals to see what they're doing. And because I do believe some are making progress on it.
We will definitely take that back.
Yeah, thank you. And I know with Raji, I've talked about some examples and getting some of those folks to share what they're doing. So I know that there's some follow-up on that the team is doing. But good.
And it is commendable to note, even with the workforce levels that you had noted previously still were somewhat lower, the nursing services still were not only meeting their goal, but with the stretch goal. So that lets us know that those that are there are certainly giving their utmost. So thanks for that.
Thank you, Director Stewart. Yeah. Would echo that. Remote participants, any questions, comments? All right, to a Providence Hospital Site Review. Thank you, Irene, with Rafael Pareo.
Good morning.
Good morning.
My name is Rafael Pareo. I am the Director of Nursing Operations at Providence Hospital. So for our OpEx dashboard, we have 6 categories. So the first one is under patient experience, the survey return volume. We have not met our quarterly goal of improving from our baseline by 3 surveys in quarter one. We did add 2 new initiatives. We added survey reminder, like a trifold that we are placing on the patient bedside tables once CVS cleans, just a gentle reminder for the patients to fill out the surveys. And then also we are reminding patients during our discharge callbacks to fill out the surveys. For nursing communication, we are just shy of meeting our quarterly improvement rate of 0.613% for our top box score in quarter one. For quarter two, thus far, we are making up for quarter one, with April coming in at 80% top box, with only 5 surveys returned. Our rolling 12 is trending up, but still below the baseline at this time. Likely, this is due to the low survey return, so therefore making our scores variable and not statistically significant at this time. For clinical outcomes, sepsis, our rolling 12-month is still trending better than our stretch goal. We're holding steady for quarter one and did not trend down, but broke even, meeting our quarterly improvement of 3.33% increase in sepsis compliance. Currently, our 12-month trending is at 66.67%, and right now, April, we are at 100%. Our end number is 1, but we're going to take it. For falls, our fall rolling 12-month is better than baseline. We have met our quarter one goal by reducing the falls over the expected improvement. April did have 2 falls, and currently our rolling 12 is at 17. We're left without being seen. We have met our quarterly expected improvement for quarter one and already ahead for quarter two, with April coming in at 0.81% left without being seen, which is also better than our stretch goal of 1%. Our April rolling 12-month came in at 2.58, better than baseline, heading towards our goal, and we believe we will meet that rolling 12-month within no time. And then the ED2 decision admit to depart has met the quarter one reduction goal. We are continuing to see this trend into quarter two, off with a great start in April, coming at 86 minutes. April rolling 12-month comes in at 120 minutes, which is at our goal. And then the next slide is just more granular, but any questions for Providence?
Great work on left without being seen. Yeah, that's an honor.
Thank you. I know Dr. Allegretti is on the line. Thank you to Dr.
Yeah.
Allegretti and his team.
Thank you for that work. Any other comments from remote participants? Thank you.
Thank you.
We'll hear from Craig Williams for ACHN site review.
Good morning, Craig Williams, Chief Administrative Officer. I get to work closely with the ACHN team, and so I want to report out our progress. We have 6 areas of focus, and the good news is that across those 6 areas, none are not beating baseline or meeting goal. 1 is actually above stretch goal, and 2 are meeting the goal, and 3 are better than baseline. The first section there is the patient experience. Staff working together for you above baseline for the rolling 12, and we're starting to see movement towards the goal. We've recently, in primary care and specialty, we have 2 different task forces that are working to address this specific goal. In specialty, I'd like to mention that they've actually created a task force that's focused on reducing appointment backlogs and improving wait times for new patients. A key change that they implemented in the past month was they've discontinued the practice of automatically rescheduling no-show patients so that they can save those appointment slots for folks who have more urgent needs. And we are requiring patients that don't show to do a little bit more work to get back on the schedule, like calling and rescheduling their appointments. So it was actually a controversial decision, but we're starting to see some gains from that. So we're happy about that. Under HEDIS, our breast cancer rate is at stretch, and we're meeting our quarterly improvement. It's incrementally above our expected. Hypertension, we're meeting goal for April 25, but what's been happening is that our denominator for patients with hypertension is growing, while our numerator is also growing and improving. So we're sort of running the standstill a little bit. So, need to continue to work on that. Obviously, a difficult patient population, need to provide more education around that. The last set of goal is around our primary care empanelments, and we have not met goal, but we are better than baseline. We have working groups under our value-based care model that are addressing outreach to get patients in care and close care gaps to ensure that not only are we getting new patients in the door, but we're not letting patients fall off the back end and not engage in care. We actually had a full day value-based care retreat last week that was very well attended and a lot of excitement in the room with some really great plans coming out of that.
Thank you. And so the only difference on the hypertension, you're seeing it from May 2024, June 2024 to now, is this denominator?
Both numerator and denominator have been kind of, growing. So we've just seen more patients with high hypertension, which even though we're improving the numbers that we're addressing, the base is growing. So the percentages aren't changing as fast as we want.
Any other? Yeah.
With the patients that are no-show for their appointment.
Yep.
Are there any type of, have you identified any patterns, like any type of disease patterns that are not showing up?
We see a pretty consistent show rate across our specialty care. It's about 70. Right now it's 78%, which is about 2% higher in the last quarter than it's been in previous quarters. We attribute to that gain. We've launched a new patient engagement tool called Terra, which we think is doing a better job of reminding patient appointments and create more opportunities to either reschedule or show. But you know what? We haven't. We certainly see at the specialty level some variation, but I can't specifically point to anything that pops out. It's worth looking at.
Yeah, I was just wondering if some of them could be done telehealth.
Yeah. Good point.
Thank you.
Sure.
Thank you. Other comments?
I was just thinking, not doing automatic rescheduling in a way is actually very innovative in many ways, because people just don't show up if you do like next automated scheduling, appointment. But do you see improvement in terms of people showing up for the next appointment?
Well, what we see is that there's frequent flyers that don't show and continue not to show. And we have a policy around that, which we would, can eventually disengage them in care. A lot of the way our scheduling systems work, it's hard to actually pick that up. So that's a piece of it. I'd have to look to see on when we do reschedule if that show rate is any different. I haven't measured that specifically. I also should mention too, we're not really willy-nilly just canceling or not rescheduling. We're actually engaging with the physician to say, hey, this patient didn't show, it's okay to not auto reschedule. In the case there's a significant issue that we need to address.
For those that sounds like that you may have identified as being more likely to not show for appointments, have we considered what they might need in addition, such as a program that might address any structural or social determinants of health that may be factored in, including in those missing appointments? Because unfortunately, they may be sometimes those of highest need, and then we only get them when they're at the highest acuity. Any maybe additional motivated appointments that might address some of their social services needs that might help in engaging that, or frequently we might also see some behavioral health issues that may come into play with no-shows.
Agreed. Yeah, let me bring that back to the team, because that's really important.
I know some of the more innovative models are trying to see, hey, if we have folks that are no-showing, what may be happening, and how can we help facilitate that? Because then sadly, those needs go unmet until they become more emergent.
Agreed. I mean, we definitely pick up some of that in our value-based care work and closing the care gaps, right? Because we're engaging with them outside of, their normal course of care. But for patients that are just referred to, especially our part of our primary care base, I think, it's a little bit more difficult, but I think we should take a look at that.
I think there will be some of that, to your point about value-based care, as we enter into an ACO agreement and start restructuring kind of how care management engages, those types of, the next day phone calls if they're in the ED, if they miss their appointment, what's happening with, how do we engage on kind of a deeper level and address those things that you're bringing up.
And I know the West Side well, and I know the South Side had a Medicaid program that was supposed to be actually identifying those folks who may need particular social health needs, having a community health worker, having a patient navigator basically assigned to them. So that peer service is also really to improve that as well. Thanks.
Other comments, questions? And this will go into, this will sort of connect to the regulatory update, but Centers for Medicare Innovation put out a strategy perspective this week, which also shows the movement towards health promotion, chronic disease management, ACOs embedding incentives around prevention, screening, and related items on chronic disease. And so I think that thinking through that in the context of the ACHN strategy as well, where it's relevant on county care makes sense. And this is where the integration, that with public health that the county has is important.
Great. I did want to highlight one thing for the past month. We're at our lowest rate on lag time from ED discharge to primary care visit. So for the first time, we got to 12 days, which is something we're really proud of. There's been a lot of work of our contact center, which is led by John Prendergast. I just want to mention that.
Yep, terrific. Congratulations. And great to see the positive work at ACHN in terms of the data here. So thank you. All right, we'll have our report on quality patient safety matters, regulatory accreditation updates. Joseph Catena. Good morning. Thank you.
Got some updates since the last time we met. For regulatory updates, Joint Commission survey of Provident. As a reminder, this was the assessment visit we had back on March 4th. We had one deficiency correction that we submitted. On May 1st, we did receive Joint Commission confirmation for the submission and approval, and we were compliant as of May 2nd, so that's great news. As far as updates, just an overall, we've got currently in process with the Provident update. We did have an update for the Bronzeville Clinic as far as behavioral health that I submitted back in the middle of April. And I did hear from the Joint Commission, just an update to this group, because we have what's called a transition of substance disorders, or SUD, that transitioned over. Not a new service, but did transition. The clinic requires an extension survey per CMS in medication management. So Joint Commission did reach out to speak to me. We can expect one surveyor for approximately a day the next 4 to 6 months. So I want to make everybody aware of that. As far as continued updates with the Joint Commission on the application, I am updating at the middle of next week primary care in the PTOT rehab portion. It's due by the 20th. I guess it's actually Tuesday. And the overall Provident, everything, when it rains it pours, the overall Provident application is due by early June as well. So I'm working behind the scenes on updating that information. Just the status of that. We did have an Illinois Department of Public Health complaint validation visit on patient rights. You may recall back towards the end of March, beginning of April, 2 surveyors for 2 days. We are still waiting on that report, and it just hasn't come yet. But again, it's not. I think this is fairly standard. Sometimes it can take some time to receive that. So I am waiting to receive that. We'll give an update in the coming month or months when that comes through. As far as imminent surveys, Stroger IDPH outpatient dialysis. This again we've been waiting for this since December. It's expected at any time, and again it's months behind. But at this point, I will update the group every month, as we continue to wait on that until they walk through the door. But it's anybody's guess at this point. It could be later this summer. It could be in the fall. So just want to give a status update on that. Next slide, thank you. As far as recent surveys, we did have, you may recall, at the beginning of April, Joint Commission primary stroke recertification. One survey over those 2 days. Survey was really complimentary on the program. We are currently working on what's called our evidence of standards compliance on the one setting we have. The draft is in progress. We expect to submit that after a review from leadership at the end of this month. And then I'm going to give some updates on upcoming surveys. The one that will be coming up closest is the Joint Commission Healthcare Equity Certification. It will be our initial certification. did do a document upload, on April 22nd. And we, again, behind the scenes preparing for that. We do have set survey dates now, compared to last time we met. So we're looking at June 2nd and 11th, Tuesday and Wednesday. One survey, we do have information in the survey as well, and we have the agenda. The reason it's 2 days because we applied as a system. So the first day we'll visit Stroger, the second day we'll visit Providence. What else? American College of Surgeons bariatric accreditation that's going to happen later this summer. We do have a set date for that. Friday, July 11th, one-day survey. Preparation is underway behind the scenes on that. We also have American College of Surgeons Trauma Center certification a little bit later in the summer, and again, we have set dates for that. We're looking at August 12th and 13th. It's Tuesday and Wednesday. This one's a little unique because it is a virtual site visit, so it'll all be via computer, and we're preparing behind the scenes on that. And lastly, a little bit further out at Stroger, we have the Illinois Department of Public Health EMS Resource Hospital Site Survey. You know, we're waiting again. Last I was informed on some equipment updates that we are expecting. We're looking at late fall, early spring to be prepared for that. And that's, again, some changes last month. But that's what I have for updates. Can I open it? Any questions? Answer.
Thank you, for the work on this. Any questions, comments?
On the health equity, they took down, Joint Commission took down the status of any hospital in terms of the health equity certification, and they took it down completely from their website. So they said hospitals can still get surveyed, but there won't be any announcements or anything.
Yeah, there's been, again, I mentioned to the group last month, previous month, people were asking the changes in administration, will there be changes? And the ones that I was, you know, they called me directly to speak with me, alert me about it because they knew we were coming up, you know, in the coming months. They mentioned some of the standards and elements of performance will still be part of the standard, I guess, standards, but they will be optional as far as if we want to meet them. And Dr. McKay, as you had said, we're going to move forward as we were. Great, but at this point, if we were to, let's say, fall a little short, they can provide us, you know, some updates to how we can, you know, meet that best practice, but they won't score us negatively. It won't be a deficiency on us. So that's one thing.
Right. I'm, you know, again, we all know equity is so important for care across and cost savings too.
Absolutely.
Yeah.
I feel like
It is what it is.
yeah. You know, we will move forward with it. I think we're going to do very well. I think it's a nice thing for a county to have.
Yeah.
But like you said, if the certification didn't exist, we've been going that route anyhow.
Right.
So I think it's just going to look good for us, and it'll be interesting to see in the future where this goes. And so I'll keep my finger on the pulse of that, and obviously we'll update the group as I get more information. So.
I think it's also probably a meaningful thing for the staff and the clinicians to know that we are making progress and a commitment to this. So that is worth you know, doing something to communicate or celebrate, you know, with the staff. Because I think, regardless of what happens externally, you know, we're committed to this work and continue to advance it. And can't get to the results and outcomes without their hard work, dedication, contribution. So I think that, and then this may be more for Dr. Makaitis as well, but is the team thinking through scenario planning as it relates to tariffs, budget reconciliation, and the impact on the county?
So we are. We've been working with Shannon and team in terms of tariffs, and our partner, Busy at our GPO, has been providing a lot of guidance. We've been looking at, you know, how do we prepare for potential increases in costs.
Yeah, because all those things may have an impact on quality, from supply chain to care delivery to cost to affordability. Those positions.
And to dovetail on what you said, Director, our public and our patients need to know that we're still focused on addressing health equity. And working in the community, we've already been able to see, and thank you for continuing to uphold and move to that some hospitals are continuing to press forward. Some hospitals have capitulated before even being asked. And the community and general public is seeing that as, was this something that you were wanting to do to begin with and as a goal, Or was this something that truthfully was
Flavor of the month kind of.
yes, our result of the protest of 2020? And so how we uphold these goals and whether we abandon them, our patients and public are certainly watching.
Yeah, Shannon says it very nicely. We've been doing it for almost 190 years. It's who we are, it's what we do. You know, and she says we were doing this before the word equity was considered sexy, right?
Sure.
Like it's who we are.
Well, I think the opportunity to be more precise about the language, you know, and it's optimal health outcomes for all and closing care gaps and health gaps, which is, and I think that people can understand that.
Right, and no matter what we call it, it's still doing the work. Because sadly, if we look over the course of our history, we've had Reconstruction and pushback, affirmative action and pushback, and DEI and pushback. So as long as we're continuing to do the work, whatever name it may have, we're still doing the job.
Yeah, it's interesting to your point, Director Butt. You know, I saw the CMMI update with, you know, leading into innovation, leading into value-based care and kind of looking at upstream measures of prevention. And it's where we've been heading, is where we're focused. It's interesting that they're framing it as that, but at the end of the day, that really what health equity is. It's about ensuring that, you know, we're providing the right care at the right time for everybody at a, you know, cost-conscious way. I mean, yeah, that is. So.
And the other component they lifted up was technology and reducing administrative burden and clinician burden, you know, as an enabler to that, as well as predictive, you know, so to the extent the sepsis outcomes, you know, how do you get in front of that using other enablers and supports, and technology being one of them, to do predictive work and intervene earlier. Any other questions, comments? Directors online? No. All right, thank you, Joseph, appreciate it, the update. So we have, the committee will not be going to closed session today, so if there are other questions or matters to discuss, we can move to adjournment of the meeting. Anything directors want to bring up? All right, we are adjourned.